Thank you for that interesting presentation. About halfway through, I was wondering if she was making it up, but apparently not. Um, We now have about, let's make it about 10 minutes for discussion before our break. And once again, we'll start with the roundtable members. If you'd put up your tent and introduce yourself. Bernard?
Uh, Great talk. Entertaining, but also very meaningful. One thing I want to comment or ask you about is really this issue of patients using the look of the medication as a real tool to understand what they're taking, when to take it. And we've been experimenting with asthma action plans, and we know that many of our families, they use the color of the inhaler to figure out what the medicine is. And we've been experimenting with the different colors. Of course, there ought to be standardization that all albuterol is one color and all steroids are another color. But I guess the question embedded in this is, what do you think are some actionable items to use the look of medications, or have you thought about it? Because I do think it's
Identified one. I think people respond to color. I mean, the technology goofus that I am just recently got a Hewlett Packard printer. Put the green in the green, the blue in the blue. You know, I don't have to understand. The names of those things are not helpful to me. You know, I just need to know how to use it. And so I do think people respond to color. I think we have the ability to figure out how to make things easier, and instead of just doing it the same old way. So I think you're onto something looking at color.
Just to make it public, Rob Logan, National Library of Medicine, we're about to launch a website. We've already got some that are in beta where you can go on and really see very high quality images of pills, colors, etc., so you can identify what they are. Okay, it's taken a long time to do it. It will be released this summer.
Terry, just brilliant. That was wonderful. And I'm sorry that it had to be based on a personal experience, though. And in regard to issues of pills and numeracy, the instinctual sense of a numeric world that we live in is that small is small and big is big and big is more powerful than small. And as several people had pointed out at other conferences, especially when working with elders, very often when people move from a name drug to a generic drug, the generic drug is different in size. And there are times when the size of the stronger pill is smaller than the size of the weaker pill. And this truly throws people off and truly explains why people don't take their medicine properly, because they'll see what's going on and they'll take a double dose because they know that adds up to the size of the pill they were taking before. So it's definitely a system level issue and difficulty that we really must address. So it's color, it's size, and it's also name. A scholar from Dartmouth who was on a committee that Andrea and I were on together had finished a small study several years ago that looked at names of drugs. And names of drugs are often chosen because of the sound. So drugs, for example, that are meant to address a really strong issue like the heart, all have strong sounds in them, K's and T's, and very powerful consonants. And drugs that are meant to soothe you, relax you, very often have soft sounds in them and therefore a lot of S's and soft C's and X's. And it's a psychological issue. But it also means that if you're taking medicine for your heart, which needs strong medicine, almost all of the medicines will have those letters in it that connotate strong. So we have to also take political issue and we have to take policy action that stops this absurd practice that puts unnecessary barriers in front of people. So I'm so glad that you named so many of them in your own experience and your own talk. And thank you for that. And we all have to take action to make changes.
Thank you, Terry. That was very practical and very grounded in reality. I appreciate that. And I, too, take my wife's calcium pills instead of my glucosamine, so don't feel bad.
Hi, Terry. I'm Kim Parson, and I work in the Consumer Experience Center of Excellence at Humana. And I was very interested in the visuals on the patient-centered label and the research around that, and would like to understand more of the research that went into this and the effectiveness of it, because in terms of patient adherence, the ability to understand, you know, just what people are being asked to take and when is the struggle that you illustrated is huge. And then I'm hoping also that when we get into some more discussions and presentations later, that we'll hear more about iconography and different situations where iconography and visuals can be more helpful in decision making, either about plan choices, either about medication adherence, or any number of things to help us navigate a very personal and challenging world. Because, as I like to say, an appendectomy is not an appendectomy is not an appendectomy, and it's all very personal, and depending on what doctor you're going to and what their instructions are for you, and even around the cost, right? Trying to understand what that looks like. So very interested in visualizations and iconography as to how we can help break down some of those barriers for consumers. Thank you.
I think Mike Wolf is going to give some specifics about the research, but I will just say one thing. Part of what we've done is just put one foot in front of the other, and one little baby step and another little baby step, trying to figure out what makes more sense. I mean, we know that what we got, as Rima's saying, is not working. So we didn't know exactly what would work, and this is where we are in the process now. Maybe we can come up with something that's better than that. But it's like we have a series of studies where we just put one foot in front. I was just talking about you. Are you going to talk about? Yeah, don't walk out on me. So, are you going to talk about our research? Are you going to talk about the label research this afternoon?
I'm going to go through some of the solutions, but like the data that you already showed up as far as the English struggle with the.
Yeah, and the
I'm going to walk through some
ARC study.
strategies.
Yeah, okay. But I was just saying that part of what we don't know, there's no magic bullet. And so we keep doing one baby step after the other to try to make it better and better. But the other thing I will say is, I think that no matter how good the final label is or the final pill shape or whatever, that some people with low literacy are going to need some personal help, that you can't just solve it with a better label.
Hi, I'm Susan Pisano, and I work in America's Health Insurance Plans. First thing, it's really good to see you looking so good, and didn't take any of the sass out of you, that was for sure. Um, I mean, one of the things that your presentation told us, which I know from my own experience, is that, you have every advantage known to man, and it's still happened to you. And I know that you focused on what went wrong. Was there anybody or anything that was helpful to you as you went along that could, be useful for us to know about?
Friends.
But nobody within the system.
I called Ruth, was the first call. Mark Williams, I'm surrounded by physician friends that really came through for me. The surgeon at the Cleveland Clinic was great, and the procedure, the day before was really good. I really struggled with the insurance, but I was sort of an insurance virgin too. I didn't know how to work the system. And I tried to be friends and friendly and have a nice, pleasant tone and not an irritated, bitchy tone when I talked to them. But I would get irritated. I can't tell you how many times I called my husband. I said, I'm just writing him a check. I can't stand this anymore. And he said, no, don't write him a check.
But the people who helped you the day before, who went through that process, was it simply a matter that they answered your questions? You know, what was it about that day that was particularly helpful?
It was organized, so it was really convenient. I went from one appointment to the other. Everybody who saw me had the tests they needed to see. Everything was in line. I didn't have to come back. I didn't have to go to another building, see another provider here, there, and yon.
So it was organized with you in mind.
Yes.
Okay, thank you.
I'm Margaret Loveland. I'm with Merck. And from a pharmaceutical point of view, an industry point of view, I can understand what you mean about the generics. I just wanted to make a comment. Singulair for asthma went off patent last June. The day after, there were 20 generics that were approved that came onto the market. And each one looked a little bit different. So you can understand how patients were immediately, confused with not getting their Singulair. There were 20 of them out there that had all been previously approved by the FDA the minute that, June 10th, we went off patent. And even my own husband, he gets his medication and he says, why does it look different? Well, the active ingredient is almost the same. I mean, they can have like a different side chain. Sometimes it's supposed to be the same, but it's not completely always, but it's supposed to look, be the active ingredient. But the excipients are different, the inactive ingredients, so they can have more or less or whatever, but it's considered a generic. The other comment I wanted to make was your comment about cost. And when I relate that to the Affordable Care Act and all these people that are going to have to, get health insurance who have no idea of what costs are. I think this is a huge problem that somehow has to be translated to them that, they're getting insurance for a reason because they haven't had insurance for a reason. And I think, this is a big problem in communication to these people. That was just a comment that I made when you said it's a secret, really.
Ask you a question?
Yes.
Are y'all considering making these names easier?
Rima's comment was good. There've been it's very hard to get new names. I mean, I'll tell you one. We just submitted and we got a letter saying we have to go with a lower dose of sleep medicine, Suvorexant. You consider that easy? Not really. For another osteoporosis, Adanicatib. You know, there's very few, one or two syllable names. I think they've all gone. Really, yeah, we would like to have them sort of, easy names that get in. Singular was probably the last good name, and it's gone.
Thank you. We're over time already, so we'll take our break right now, which will end at, let's make it about 1:45.